Hi guys, this is Jody, and I'm going to go over what I would have reviewed in class, just to make sure that you get all of the content. So when you click into the Class 3 folder, I want you guys to look at the videos that I posted. First, let's talk a little bit about this image, because when we talk about heart failure, really what you need to know is that it's very prevalent in our society. There's a lot of heart disease. It used to be a long time ago, and even at the time when I was first entering nursing practice, if somebody had a diagnosis of heart failure, really their life expectancy was about a year. We did not expect that people were going to live very long once they had a diagnosis of heart failure. But really now, there's so many treatments and options out there. There's a lot of lifestyle modifications and things that people can do to help manage it, that people are living a lot longer with a diagnosis of heart failure. This image that I give you in the class folder is really something that we should be educating our patients, because if it is managed, a person should be able to live a quality life with heart failure. That's really the goal. We don't want somebody suffering so much that their quality of life is poor, right? There's really no purpose to that. We want people to have a fulfilling life with quality. And in order to do that, they really can take some steps on their own to help manage their heart disease. So they need to know when to call, because patients come into the hospital. If you work in an emergency department, you may often hear these patients get termed as frequent flyers, and sometimes they're blamed, oh, they went out and ate a ton of salt this evening. Of course, they're coming in now, they're fluid overloaded. Really, we want to educate patients on what to do when they get in that, situation, because it is not, if you think about how hard it is to change habits, when somebody has this diagnosis, they're having to change their diet, they're taking medications and all of this stuff. It's not going to be unusual that they have a misstep here and there, or that their heart just gets overwhelmed and they end up going into a heart failure exacerbation. So we want them to recognize signs and symptoms early so that we can intervene and prevent a hospital stay. So usually what we would do is give the patients this kind of teaching form that tells them when to call 911. So really where they want to be is in the green. They want to be making sure that they're checking their weight daily, because if they're noticing a weight increase, generally that's going to indicate fluid overload, because it takes some time to put some weight on. Not for me personally, but for most people, if they're maintaining the same lifestyle, the same type of diet, their weight should be very stable. So where we want to be concerned is if they have a weight gain of 2 pounds in a day or 5 pounds in a week, because that's generally going to indicate that we have fluid weight gain. So we want them to keep their record of their weight every day, and to notify the doctor if they're noticing that weight gain, so that they can do an intervention. They can maybe increase their Lasix dose, talk about diet again, that type of thing. We want them taking their medications as directed. You will hear a lot of patients sometimes will be non-adherent to their diuretic because they hate to have to run to the bathroom all the time. So really teaching your patients strategies as to when to take their diuretic. Take it first thing in the morning, first thing when you get up, because generally, these patients aren't, getting up in the morning and having a lot to do. So if we can get their morning routine, take it first thing in the morning when you get up, and that way, you're going to the bathroom a lot in the morning. It's going to last about 6 hours in your system. But then, you have your afternoon where you should be pretty good. And then not taking it right before bed, because we want patients to get a good night's sleep. We don't want them to be getting up in the middle of the night and having to run to the bathroom, especially because these patients are probably on blood pressure meds too. And we don't want them getting out of bed quickly, because we can drop their blood pressure. That increases their risk of falls, right? So the best time to take their diuretic is going to be first thing in the morning and then in the afternoon, at least 6 hours after their first dose. Okay, so it could be morning and dinner time or something like that. They should be watching their sodium intake, so 2,000 milligrams or less of sodium. Well, 2,000 milligrams is actually like we want them to get some. We all need some sodium in our diet. So about that 2 grams of sodium a day is good. Okay. And then they should be active. Again, the goal is going to be 30 minutes a day, or at least 5 times a week, right? That's American Heart Association. Now, in reality, if you have somebody with an ejection fraction of 15% and they're living with a diagnosis of heart failure, 30 minutes a day is a lot. So you'd have to individualize that to that patient. I had a patient who would get on her treadmill for 8 minutes a day. She had an ejection fraction of 8%, had gone through many cardiac things. So, she, that was what she could do. She could walk very slow on her treadmill for 8 minutes a day, and that's what she would do. So you do want to individualize that. And patients need to be calling their doctor if they have questions or concerns. So if they get into this orange, or really it should be yellow, call the doctor if they're a little bit more short of breath, if they have pain or swelling in their belly, trouble sleeping, that dry hacking cough. They should really be notifying the doctor, if they have, a significant weight gain, or if they notice that they're starting to gain that weight, because we might be able to do an intervention here. When they need to call 911, is when they have chest pain, severe dizziness, or severe shortness of breath. That's a 911 call, okay? To the doctor with that weight gain, because again, if they have that weight gain but they're not having the shortness of breath yet, we can intervene. We can give them some extra diuretic, talk to them. We can do an intervention. If they're having trouble lying flat, or they're noticing increased swelling. So this, on the second portion of it, would not be a 911 call, but it's an absolute call to the provider so that we can get an intervention. So as you go down into these videos, I have 3 videos for you. This CardioMEMS one is really good. You're not going to get tested, I can promise you, on the CardioMEMS device, okay? But I think it's really good for you to be knowledgeable of this device, because it is a detector. So again, with heart failure, the goal is to prevent hospitalizations. We want patients living at home and as comfortable as possible and as stable as possible. The CardioMEMS is going to pick up changes within that pulmonary artery. So we know that if there's fluid buildup and increasing pressures, that the CardioMEMS will detect before we ever see a change in weight or symptoms. And so it really triggers early intervention. And again, that intervention might be some diet teaching, reinforcement, because obviously the patient's been taught, but reinforcement of teaching, or it could be a medication change or adjustment. I have, if you want to see a little bit of what transpires during heart transplant is testable content. I do want you to be aware of that. It is the last stage effort of treating heart failure. So you may have patients that have a ventricular assist device, and that ventricular assist device might bridge them to transplant. But heart transplant would really, for some, be the last thing for heart failure. Okay, it's just for end-stage heart failure. And then I do have a presentation again on VADS, but this is a really interesting story of a patient with a HeartMate that is a ventricular assist device. You will often hear me say LVAD, which is a left ventricular assist device, because that is the most common. And there is a right ventricular, so an RVAD, but generally what you're going to see is the left ventricular assist device. And to remember that not all patients that have heart failure because they lived a poor lifestyle and they had a heart attack. It's not it. There is pregnancy-induced cardiomyopathy. So if you think about pregnancy increasing that need, that perfusion, that vascular load by 50%, that puts increased workload on the heart. It could be somebody that has just high blood pressure, essential hypertension, which again, that strains the heart, puts pressure on the heart. So there's different risk factors for for heart failure. And I think her story of living with a VAD is just a good way to see what that VAD can do. So you may have a patient who has a VAD like this lady, and it may be to get her stable enough and give her life expectancy until she can get to the point of transplant. Because you have to remember, with heart transplant, hearts are not widely available. And of course, when you get it, it has to be compatible. And so there's a waiting list, and, you have to be sick enough to get the transplant, but not too sick that you would not survive surgery. So, there's things there where heart transplant can take a long time before you would get a heart. So sometimes a patient would end up with a ventricular assist device in order to bridge them to that transplant. The other video I have you on is super short, and it talks about MODS. This is a good thing to remember as you're going into our exam, as you're going into NCLEX, and as you're going into practice. This is medications, activity, weight, diet, and symptoms. These are the things we need to be teaching patients. So if you can remember that acronym MODS, and remember what the medication teaching would be, so you need to study your meds, what that activity recommendation would be, how often we're telling them to weigh themselves and how we would instruct them to weigh themselves, what their diet should be, and they need to be informed of the symptoms so they know when to call the doctor. That, again, is this form up here, teaching them the symptoms, right? Is what we would teach the patients. So those are the 3 videos you guys can go through and watch. What I'm going to do now is open up the heart failure treatments presentation. You do have the slides in order to print these if you would like to. There are 3 treatments that we'll talk about for heart failure besides conservative management. So when you think about conservative management of heart failure, that's really going to be lifestyle modifications. So adjusting the diet, the activity, and then adding in those medications. Now we're going to get more invasive, and we're going to talk about a biventricular pacemaker. So you guys should have or will talk about pacemaking and pacemakers in your 222 course. What you really need to know with biventricular pacing is it is very specific to a patient with a diagnosis of heart failure. And then we will talk about ventricular assist devices, and then heart transplant. So the first thing we're going to talk about is biventricular pacing. So you can see it's going to be the same process as implanting a traditional pacemaker. The difference is the amount of leads and how it is pacing, and frankly, why it is pacing. So it paces both the right and left ventricles, but its purpose is to treat symptoms of heart failure for clients with moderate to severe heart failure. In other words, if you have a patient with a healthy heart muscle, but they're getting a pacemaker because they have dysrhythmias, they would not qualify for a biventricular pacemaker. If you think about the ventricles, we talked about this a little bit in the CAD class, is the ventricles are the main pump of the heart. They give you that main squeeze. If you have heart failure with a decreased ejection fraction, and so you should know that a healthy ejection fraction is anywhere from 60 to 70%, which basically means that every time that heart beats, that percentage of blood is being perfused out to the rest of the body. Okay? It doesn't completely squeeze and completely deflate to push out 100%, right? Because it's constantly pushing out and then blood is coming back in, right? That's your lub-dub, your systole, diastole. So if you have somebody with a very weak heart, and in order to qualify for a biventricular pacemaker, the patient is probably going to have an ejection fraction of 30% or less. We want to kick both ventricles with those leads, with those pacing leads, in order to give those ventricles more squeeze. in order to kind of boost that ejection fraction a little bit. It can also include an ICD because you have to remember that when patients have a sick heart, that it can be irritable. So we could see dysrhythmias as well. So if they need that ICD portion, they can have that as well with the biventricular pacemaker. What you will see on telemetry or the EKG is 2 pacer spikes, and a lot of times these are much closer. So this one I made it as easy as possible to see. This is a better rhythm over here. Actually, over here it's not great because it almost looks like it's coming before the peak. What you'll see is 2 pacer spikes before the QRS. Because remember, the QRS, this here, represents ventricular depolarization. So you're going to see those pacer spikes before ventricular depolarization. Okay? It's before the QRS complex. That would let you know right away. When I had students in clinical, we were on a clinical floor. It was not a cardiac floor, but they did have telemetry. And they had a patient on telemetry. And I was so proud of my students because they said, oh, I have this patient. This patient is here for, there was some kind of trauma, okay? But the patient was on telemetry, and the student was looking at the telemetry, and they said, I think I see 2 pacer spikes. That patient has a biventricular pacemaker. That patient must have a history of heart failure, okay? So you see how that student was able to make those connections, and the nurse that worked on the unit was like, I don't think that patient has a history of heart failure. So sure enough, they went to the chart, and yes, the patient had a history of heart failure. And that student and I were able to talk to that nurse and say, yes, patient with a biventricular pacemaker, that is a treatment for heart failure. So in other words, again, you're not going to see a biventricular pacemaker on somebody who just has a history of dysrhythmias. That would be just a traditional pacemaker. That could be A-paced, or V-paced, or AV-paced, right? Biventricular is 2 pacer spikes before your QRS. We are kicking both ventricles to give that heart more of a squeeze to get more of an ejection fraction. Nursing care, very similar to it's actually the same as a pacemaker. So when they have that pacemaker implanted, they really want to keep their arm below shoulder level. Okay, it's going to take time for those leads to scar into place, and therefore they don't want to lift their arm above shoulder level. If they do, then there's always that chance that they can lift those leads out of place, and then they're not pacing appropriately and pacing the ventricles. I'm sure you learned with pacemakers that if you see a patient who's having hiccups, afterwards we could be pacing the diaphragm, so the leads could be misplaced. We want them to report dizziness or weakness because we might not be giving them enough of heart rate, okay? So I'm not going to get terribly into, for this course, or testing into fixed versus demand pacing. But the reason you might see fainting or weakness is if you think about your heart rate, okay? If you're resting, your heart rate's going to be a lot lower, right? We don't need as much perfusion. The heart doesn't need to pump as fast to perfuse our body. When we're up and moving around, our heart rate goes up, right? Because we need more perfusion to give us the energy and to energize our muscles and all that stuff. If you have somebody who has a fixed pacemaker and their pacemaker is set at, say, 70 beats per minute, if they're up and moving around, 70 beats may not be giving them enough perfusion if they're not going to pace over, or their heart rate or heartbeat is not going to overcome that pacemaker. Because a lot of times we have these patients on beta blockers and that type of thing. So that's really the reason why you might see some weakness or fainting. We just might not have that programmed correctly. We don't want them injuring that pacemaker site. We want to watch for hematomas at that site, infection at that site. Anybody who has any kind of device implanted will receive an ID card with the manufacturer information of that device. And we want to check their pulse, okay? So we want to make sure if their pacemaker is set to pace at a certain rate, that their heart rate is at least that rate. So in other words, if it were a demand pacemaker, which is only going to kick in if, say, their heart rate drops below 60. So let's say they'll always pace at a minimum of 60. And if we're checking their pulse and their pulse is 50, there's an issue, and we want to make sure that that's addressed. Now we're going to jump into ventricular assist devices. Okay, a lot of times, like I say, I just jump in and say LVADs for left ventricular assist device, because generally when you have a ventricular assist device, it's going to be left side. It can, again, be used for on the right side of the heart, and it can be a BiVAD, so for both right and left. The reasons that a patient would have a ventricular assist device is to, one, bridge them to transplant. Again, maybe they are at end stage and they really do need a heart transplant, but it's not like, you're going to get one right away. It takes time to get that heart, but we want to make sure that they have quality of life in the time and that they're stable enough to get them through to get that transplant. So they could be having that device until they get the heart transplant. It could be what we call destination therapy. So that could be for a patient who, one, doesn't want a heart transplant, or two, does not qualify for heart transplant for whatever reason. Okay, it could be a history of cancer. It could be whatever they look at to say, this person would be a good candidate for transplant and this one wouldn't. If they're really not, because, they've maybe aged out, or they have a history that, they would not be a person for that, would be destination therapy. Now, I will tell you that there are some patients that started out to bridge to transplant and they end up destination therapy because they end up with an infection, a driveline infection from their VAD, and that may prevent them from getting a transplant later on. It can also be used for temporary heart failure. So this could be somebody who has Takotsubo cardiomyopathy, which is your broken heart syndrome. Sometimes patients recover from that and sometimes they don't. Takotsubo is usually something we see when a patient has a huge stressor. So when you hear the term, a person died of a broken heart, a person can truly die of a broken heart if they have some kind of stress that really impairs that heart muscle, and they have this Takotsubo cardiomyopathy. It could be that they had a viral infection that impaired their heart function. It's not always going to recover, but sometimes it does. It could be pregnancy-induced cardiomyopathy. Again, sometimes a patient, once they deliver the baby, or they give that body some time to kind of come back to normal after delivery, we could see some recovery, but generally not. Okay, but those would really be the only time that we're seeing like temporary heart failure. Benefits of a VAD: it helps pump from the ventricles to the rest of the body, so it's giving the body perfusion. It doesn't mean that this comes without a downside, okay, because there are definitely downsides to a VAD. But if you watch that story and that video that I have given you, there's good reason to, and a person can have quality of life with a VAD. There are significant risks with the VAD infection, especially at the driveline site. So they do have a totally implantable VAD, but it's not anything we've been seeing at this point. At this point, the VADs still have drivelines, which means that you have the device, attached to the heart and working with the perfusion there, but we have to power that device. So it has a cord that comes out. It is kind of goes down the abdomen and comes out the side of the patient's abdomen. And then it would be connected to the device, which is then powered by batteries. We can have pump malfunction. So the device itself could stop working. Bleeding is huge because, and I want you to note this in red, or circle it, or bold, or star it, the patient has to be on warfarin, specifically warfarin at this time. As I've been looking at the research, I have not seen that has been switched over to another type of anticoagulant. So it is warfarin that they have to be on. So bleeding is a huge risk. Okay, so we'd want to teach that patient soft toothbrush, We really want to be cautious of falls, no contact sports, that we really want to go through all that bleeding risk teaching. They can develop right heart failure if they have a left ventricular device and blood clots, okay, which is the whole reason that the patient has to be on warfarin in the first place. Pre-procedure advanced directives would be discussed. Sometimes these patients are already a DNI, because of their history of heart failure. So they would rescind those and really have that advanced care discussion. We want to confirm that they have a support team. So this is not somebody we would want to send home that lives by themselves with no support. We would definitely want to make sure that they have a good support system to help them manage their device and understand what they need to do. Informed consent. So again, the doctor really needs to go in and have a discussion as to the risks and benefits. They will have all sorts of diagnostic testing, and before the VAD is placed, they get a lot of teaching on how to manage the VAD, medications, diet, all that good stuff. Again, medications, and I hate myself for writing blood thinner on here, but I know that's how a lot of people remember it. It's an anticoagulant. Again, anticoagulants don't thin the blood, even though we call them blood thinners. Even in the medical profession, the docs will say that. It prolongs the time it takes the blood to clot, okay? Possibly an antibiotic for a while, just to prevent. They should be on home care services when they come home, and they will have VAD management teaching on how to plug in the equipment, charge the batteries. They will have readings on their pumps. You guys do not have to remember the readings on the pumps, okay? Driveline care, we will do a specific LVAD presentation, and we'll talk about that driveline care. They need to have follow-up medical appointments. They will be connected to the heart failure team. Signs and symptoms of infections, signs and symptoms of heart failure. Okay, so really when they get the VAD, we expect that they're going to have good perfusion, and that, we're not going to see the signs and symptoms of heart failure. But those signs and symptoms of heart failure, if we're seeing them, could mean that the pump is not working appropriately. And when and who to call for concerns. Collaborative care, they're going to have a lot of people involved in their care, primarily the heart failure team. That's really going to be the person at the top that's managing the VAD. But they'll still have cardiologists, they'll have the surgeon, home care, nurses, PT, OT, social workers. There's generally, when these patients come home, there's a lot of people involved in their care. The other thing that we'll talk about more when I go over the LVAD is there are very specific assessment pieces with somebody with a VAD. They will not have a pulse. Now, somebody with a VAD, sometimes you can palpate and you will feel somewhat of a pulse, but it is not the pulse that's giving them the perfusion. Generally, you won't feel anything, and if you listen to their chest, you're really just going to hear kind of a mechanical whirring in there. And that's because the VAD doesn't work by squeezing the top and squeezing the bottom. It really works by a continuous perfusion of that blood through the heart, okay? The other thing that they can have, which is really last resort, is heart transplant. And sometimes the patient will need both a heart and lung transplant, depending on what the underlying disease is that the patient had. In other words, if they had significant lung disease, which when the heart couldn't overcome the pressures in the lungs, led them to heart failure, then we know they have diseased lungs as well, and they might need that heart-lung transplant. Again, it's for end-stage heart disease. They would have to wait for a donor heart. We don't know how long that would take, so a VAD might be necessary to bridge them to transplant. Please circle, star, bold, highlight whatever you do in this. They need to be on an immunosuppressive drug so that they don't reject the transplant. Okay, so with transplant, they have to be on an immunosuppressive. Eligibility would be considered. That is way out of our realm of expertise. We do not do that unless you're specifically trained to be on some team that does that later on in your career, okay? And it needs to occur within hours of organ removal for the donor organ to remain usable. Now, they do have what they call heart in a box that they might use that, would, it would help to perfuse that organ while we're waiting to get it into the person that is receiving the transplant. Eligibility, again, don't go crazy with this trying to memorize all of this information. It's just kind of general, and it's not hard and fast. And there is a team of individuals that would be looking at the list, and there's something that might bring one person up higher on the list than another person. So, really, it's just some things that, somebody who might not be appropriate is somebody who's 90 years old, but maybe they're 90 and super healthy, and a VAD would be good for them. Another medical condition, so again, if they had like heart failure or other disease, active infection would definitely prevent them. Recent cancer, or if they're just unwilling to make the lifestyle changes. If they're going to continue to smoke, they're going to continue to drink, they're going to continue to eat whatever we want. This is not the person that we want to put a heart into, because they have to take an immunosuppressive, and we want them to take advantage of having now a healthy heart. So just some things to kind of think about. But again, don't memorize this. Don't think that this is hard and fast rules. Risk associated, rejection is big. So the big things that I want you to think about with risks associated with transplant are rejection and infection. Rejection and infection. And rejection is huge because we know they have to be on an immunosuppressive. An immunosuppressive will also decrease their ability to fight off infection. So we have to really, so they have the surgical sites that make them at risk for infection, but also because we're suppressing their immune system, they're not going to be able to fight off things like normal. So we want to make sure they're up to date on their vaccinations, and also avoiding crowds, good hand washing, all the things that they can do to prevent infection. We can see that the primary graft failure just fails, and that would cause death within the first few months. Thickening and hardening of the coronary arteries can occur. They may have side effects from the immunosuppressive therapy, which an adverse effect of an immunosuppressive would be cancer. Okay, so it could make them more susceptible to a cancer when they're on an immunosuppressive. Nursing care, when they first come into the ICU after surgery, we're assessing the chest tube site and drainage. They will cool the body during surgery, so warming them back up, assessing for signs of infection, watching their airway. And as they progress through their recovery, we're continuing to assess for signs and symptoms of rejection, which present very much like the flu. And we're also looking for dysrhythmias. We're looking for signs and symptoms of infection. Again, that collaborative care, they're going to have a ton of people involved in their care when they have a heart transplant. The biggest one is going to be that heart failure team. And that's it with this presentation. Okay, we're going to move to the LVAD presentation. And this, just so you see, gives a beautiful image of what it looks like. So you have the device here. This is where the perfusion is going through. Okay, this is what's managing. And this is why I say you don't really get the lub-dub, because it's actually just kind of moving the blood through this device here, rather than through the heart itself. So that's kind of what's pumping the blood. You'll get that whirring. This is the power cord that comes down, and then it comes out the side of the abdomen, and then the cord attaches to the controller, and this controller will have these batteries attached to it. So these are batteries right here. Okay, they're pretty cool, and I found out like inside, because this is constantly whirring and moving and turning to pump that blood through, and so that it doesn't overheat, it's actually rubies that they have in there that can handle the heat so that it doesn't overheat. Now, obviously, they're not, rubies that you would see, they're not jewelry grade, but that's what they have so that it doesn't overheat. And again, there is a VAD that's out there now that's totally implantable so that, everything would be inside, it's powered inside, and then they would not have this driveline, because this is a problem area. Okay, so if you imagine that they get an infection at the site, that infection can go right up this driveline and really infect the entire body. So we have to be very cautious. This is really where we tend. So we'll talk a little bit about the care to the site. There is a growing need for mechanical circulatory support because there is increasing risk for heart disease like diabetes and obesity in the United States. So we do, because of those risk factors, see a lot of heart disease and a lot more heart failure. So it is used for late stage heart failure. We talked a little bit already. It's about bridge to transplant, decision, recovery, or destination therapy. So that decision in there just means that the patient hasn't decided yet. They don't know if they want a transplant. So they can put this device in until the patient decides, or they may look to see if that patient is going to recover. And again, if it is determined that the patient is not eligible for transplant after they receive the VAD, then they just become destination therapy. That's really the last place they're going to go. It is depends on preload. So you guys, if you don't have a clear understanding of preload, afterload, and contractility, please go back to the prep work, because you do need to have a really good understanding of preload, afterload, and contractility to understand why we're giving medications to the heart and really why a patient goes into heart failure. So when we talk about preload, that is the volume of blood coming into the heart during diastole. Okay, so the heart during diastole is filling. That's the preload. If somebody doesn't have adequate preload, they're going to have issues with their VAD. Their numbers on the device are going to be out of whack, and that's not something that you guys need to know the numbers on the device, okay? You would look at the patient always first. So if a patient has a VAD, you're going in to assess that patient. You assess the patient first. You look at your patient. If your patient's looking at you, their color's good, they're talking to you, then you have no reason to feel like that device is not working. If you walk into that room, patient is really barely arousable, their color is pale, then you go to further assess, their cap refill is high, we need to be looking at that patient because there could be an issue with the device, and it could be related to preload. Dehydration, which could be caused by overdiuresis, can impact preload, right? It decreases volume. Bleeding is going to decrease volume and therefore decrease preload. They could also have right ventricular dysfunction. So we now are seeing a problem with that side of the heart. So preload, that is the volume of blood coming into the heart during diastole. And just so we're a little bit more clear, is that if somebody has increased preload, so they're fluid overloaded, then we would treat them with diuresis to reduce that volume load. Most frequent adverse reactions within the first 12 months after placement are bleeding. Again, they have to be on warfarin, which increases the risk of bleeding, infections, dysrhythmias, okay, and strokes. And even more specific, well, I don't want to say more specifically, they are at risk for hemorrhagic stroke because they're on now the warfarin, but also if they were to have like a recent infection and, now we're seeing symptoms of like headache, change in vision, we have to look at bleeding in the brain. So it could be a hemorrhagic stroke or an ischemic stroke if they're not taking their warfarin, right? Because that would set them up for blood clots. Assessment-wise, you cannot check a traditional blood pressure on a patient. So if you document a blood pressure and you have a systolic over a diastolic number, you are incorrect. Even though you may have put a blood pressure cuff on and swore that you heard that, which you may have, it's not a correct reading. Okay, we're looking at mean arterial pressure with these patients. So you were going to check a blood pressure with a Doppler. This, you would want to first, with a Doppler, listen for their brachial pulse or brachial perfusion. So what you'll hear is actually, it's just like you would, because you don't detect a pulse when you're listening to that. You'll hear like the whooshing. It may even be more of a longer sound because, again, they don't have that lub-dub anymore. So you listen for that. You put the blood pressure cuff on. You pump up until you no longer hear that. You release the blood pressure cuff. And once you hear that sound again, that is your systolic. That is your mean arterial pressure, which should be around 70 to 90. Okay, because again, we're looking at mean arterial pressure. So you would dock that over PALP. Okay, and you should not see heart rate documented on these patients. Again, we're not checking pulse. Okay, you would be looking at, you could just put on their VAD. In the critical care unit, they would have an arterial line. So while in the hospital, you wouldn't have to really check that manual blood pressure with a Doppler because they would have the art line in. Again, mean arterial pressure, 70 to 80 is ideal. It could go 70 to 90. It should not exceed 90. Okay, over 90 would be concerning. Infection, especially looking at that driveline site. Okay, so it is the most frequent type of infection at that site. And you can see, I mean, that's a decent size wound that we have coming out with that device that they're going to have always. Now, over time, in a healthy person that has this, that heals beautifully afterwards, this is going to seal up and scar. And at some point, you may have patients that no longer wear a dressing over that. I would always recommend covering it, even when it's scabbed and healed. But in the beginning, this would be sterile technique in changing this dressing. Okay, and the patient and their caregiver would be taught how to do that at home. And they would also have a home care nurse. They will not be getting in the shower because we do not want this getting wet at all. Generally, these patients will not shower. There are bags and stuff that they can put stuff in and kind of do a modified shower, but we really don't want this getting wet and putting them at increased risk of infection. They can have a totally implantable LVAD, was FDA approved in 2019, but we have not seen these in patients yet. Okay, and I've been asking students, and I've been looking online and doing the research, talking to my friends that are still working on the cardiac unit. Are we seeing these yet? Not quite yet. It's on the horizon. So again, sterile technique on that dressing change when doing driveline care. Urgent care would be needed if the patient had a recent bloodstream infection, they have new neurological symptoms, we would want to get them in for a CAT scan of their head because they could be having a hemorrhagic stroke. So yes, they are at risk for an ischemic too because of blood clots, but because they are on warfarin, and especially if they had a recent bloodstream infection, which is going to weaken those blood vessels, if we're seeing symptoms, it could be a hemorrhagic stroke. Anticoagulation, 24% of clients with a VAD experience bleeding due to anticoagulation therapy. So teaching bleeding precautions is really huge with these patients. Ventricular dysrhythmias. Okay, a lot of these patients already have gone through a lot of different treatments, and they may already have an implantable defibrillator to treat this, but we do have to watch for ventricular dysrhythmias. This was just a question, and I kind of bring this up during the stroke class too, and this is just to point out that, really, when you think about time as tissue, and we talked about that in our CAD class with MI, the first indicator that the patient is having an MI is that EKG, right? If they're having ST elevations, that is really our diagnostic tool, along with troponin and symptoms or whatever, that would say the patient is having an MI. With a stroke, the diagnostic procedure is a CAT scan. So with thymus tissue, whenever we suspect a patient is having a stroke, we need to get them to a CAT scan right away. Critical alarms, you might hear this, you know, we could have pump failure. For you, if you go in, you know, if you're in the hospital, take some deep breaths. Again, always look at your patient first. You might hear an alarm and your patient looks fine. Don't panic. Okay, obviously if you go in and you hear alarms and the patient is non-arousable, things are going on, then we need to look. It could be pump failure. If it's immediate, like the patient's still in the hospital, they would really work the pump to try and get the pump going, to get that perfusion going. If it hasn't been so long where we'd be worried about blood clots forming because the perfusion had been stopped for an extensive period of time. Obviously, we're going to pick that up fast in a hospital, right? So they would work the pump rather than doing compressions, because if they did compressions on this patient, they have the pump in there, they're going to do damage to the heart, you know, and there's not going to be a good outcome. The other thing you want to do is assess the drive line, you know, look for power connections, make sure their batteries are charged, all that good stuff. When you go in there, you may hear low battery alarms. You want to make sure that the patient is always charging a set of batteries. So they have the set of batteries that's in, and then at night they'll change out the batteries, be able to hook to a power machine, and so that they can charge all their batteries overnight. In the event of a controller alarm, you might need to change the controller. So the patient, when they go home, they'll be given an additional controller. And again, the patient's going to be instructed on how to do this. And generally, if they're at home, there's not going to be a nurse around when these alarms go off. So they have to know what to do. And they also have that the heart failure team's number to call in case of any, major concerns. Okay, and they would help them through. So just some kind of things to think about in class. You know, this is usually, up for discussion. You know, is it physician-assisted suicide if a client elects to have their LVAD turned off once they're near end of life? You know, and I kind of bring this up. I actually had a patient who was denied hospice because she had a VAD. And you guys, when you have Lauren's class later on, we'll get more of an understanding of this. But it's because, you know, at end of life, hospice is an insurance benefit, and it really only wants to pay for what is going to keep that patient comfortable at the end. So basically, it's kind of saying, we're now not paying for a lot of diagnostic testings or expensive medications. We're really putting that money towards maybe some home care services, maybe a hospital bed, but those things that are going to keep the patient comfortable in the last days of life. So my patient was denied hospice. She was able to receive palliative care, which can be administered very similarly to hospice. It's just not the insurance benefit. Okay, so I don't want you to think that this patient was forced to stay alive because she was denied hospice. It's just a service, but they denied her because they were like, it's too expensive to care for a VAD. We don't want to be responsible for that. You know, in general, the patients have been outliving their heart disease once they have a VAD. So they're not dying of heart disease. They're dying of cancer or other issues when they have this VAD, which is a good thing. It means the VADs are working, you know, and that patients have these VADs, you know, cardiac-wise, perfusion-wise, they're living a healthy life with the assistance of the VAD. But that doesn't mean that they might not end up with cancer or some other diagnosis that could lead them to end of life. So a doc is generally, like, we were not going to turn off a VAD. And it used to, when they first did VADs, they were stitching together valves. And so if the pump did stop working or we turned it off, a patient would die because they would not be able to perfuse through their heart. They really don't do that anymore. So if the pump started working, generally what you would see is that the patient would go back into having those really significant heart failure symptoms. That's not a good way to go, right? It's definitely not comfortable. So, you know, the VAD would stay, and then they would treat the patient other ways, and then they would manage that pump just like you would a pacemaker at the end. And so it was really, this is not testable really, it's just more a thought for discussion as to what that is, and kind of opening that up to what the whole purpose of a VAD is and what it's doing for a patient. And that is it with this presentation. And so really in class, for this heart failure class, I do a lot of like discussion of the heart failure, kind of talk about patients I've seen over the years. But I give you guys a lot of review because I have taught the coronary artery disease content and the peripheral vascular disease content, and now the heart failure content. It's really a lot of review. And so I have a lot of review items in here for you. So there is a case study in here I want you guys to work on. There is a Kahoot that you guys can go through and practice just some base questions. An escape room. Most of you have done escape rooms with me before if you were in pharm. For the bridge students, if you have not done one, as you go through the room, there's going to be questions in each room. You will put in that final question to unlock the door to the next room, you're going to put all your correct responses from the previous questions in capital letters. And those instructions are in the escape room. Okay. And then there's a little Jeopardy game, and I have and really obviously you're not going to play this like traditional Jeopardy, but it gives you some questions to go through for review. And again, there's directions here. So when you click on the link, just kind of follow the instructions of how to go through the game. So those are review items for you. So what I want you to do is complete these. If you have not done the prep work, please do so. Because there's a lot of just base information about heart failure. Really, for this class, I expect that you're coming in having looked at Pearson, having looked at my prep work video, so that you have a baseline understanding of heart failure, so that really what we can dive into is the treatment, because that's what you're seeing patients in the hospital with, is the treatment, right? So please go through that stuff. Make sure for the exam, for practice, study your medications. Okay, so I gave you that medication list. Make sure you're studying medications. If you have questions, write them down. Again, I plan to come into class on Wednesday, whatever that is, the 17th of September. And I am happy to answer any questions. So if you're struggling through the case study, if while you're, like I said, going through stuff, things are popping into your head and you're having questions, write those down. And I'm happy to answer those. And you can also shoot me an email if you need to. Okay, so that is how you guys are going to proceed with this class. Thanks.